My name is Richard Barth. I am an orthopedic surgeon at Washington Orthopedics and Sports Medicine, and I specialize in surgery of the hand and upper extremity, which means the arm, the elbow, the forearm, the wrist, and the hand, nerves, tendons, arteries, things like that. And I'm going to talk today about wrist and hand pain, specifically mostly about arthritis, a little bit about tendonitis, and I'm not going to talk much about nerve compression today. And I think Dr. Moss may talk a little bit about that. Thank you for joining us. And if you all have questions, I think Kathy's, there's a question and answer portal or something you can put the questions in, and we'll hold the questions until the end. And then Dr. Moss and I will go through and answer the questions. We generally ask that the questions be general in nature and not personal questions. So please keep that in mind. It should be a general question, not something specifically about you and your sort of particular situation. So with that, I'm going to get started. I'm going to talk about arthritis of the hand and wrist and the evaluation and treatment. So I'm going to talk about what is arthritis, who gets arthritis, what are the causes of arthritis, what are the signs and symptoms of arthritis, how do we make the diagnosis, what are some of the other things that cause arthritis, what can we do to prevent arthritis, and then how do we treat arthritis. So first of all, what is arthritis? Every week, someone comes into my office and tells me that they think they have arthritis. And then they say, oh, and by the way, what is arthritis? Arthritis simply is that the joint is wearing out. And patients say to me, well, what's a joint? Well, the joint is the part of your body where two bones meet and you have motion. And so where you have any motion is a joint. And the way that joints can move is they have to have a gliding surface. And that gliding surface is this white structure here. And I hope that you can see the little ball, but the arrow points to it. And that structure is cartilage. And that's what allows your joints and your bones to move. And arthritis is really basically that cartilage wears out, and instead of having a nice smooth surface here, you have bone rubbing against bone. So that's what arthritis is. Here's an X-ray, and you can see the black spaces in here and around here. That's where the cartilage is. The white is bone. So you can see the bones shouldn't touch each other. They should have cartilage between them so that you can have smooth, painless motion. What happens when you get arthritis, and I think you can appreciate the difference here, the space goes away and it's bone rubbing against bone. So here you can see the cartilage is all normal where I'm pointing with my little thing, but you can see where these arrows are on the prior slide. We had a space there, and that space is gone. And this is what arthritis looks like on an X-ray. Here's what arthritis looks like in someone's hands. You can see the swelling, the deformity. There can be some sort of thickening of the joint and swelling. And this is what a typical arthritic hand looks like. So who gets arthritis? Well, basically, if you live long enough, you're going to get arthritis somewhere, if not multiple places. Age is probably the single most important thing, because as we grow up, the cartilage wears, and finally it gets to the point where it wears out. People with a family history of arthritis are more likely to get arthritis. There are certainly high-risk hobbies and jobs that cause arthritis. I just saw a relatively young man, probably 60, who played rugby all the way up into his 30s and came in with arthritis in his fingers. Well, all of the repetitive trauma and injuries that he had in rugby probably played a role in this. So those kind of activities where your hands are repetitively traumatized can cause arthritis. Arthritis isn't caused by computer work or typing or things like that. Arthritis can be related to a history of injury. If you damage your joint, then you can damage that cartilage, and the cartilage can wear out quicker. People who are overweight are more likely to get arthritis than people who aren't. And especially in the hands, women seem to get arthritis more frequently than men. So what causes arthritis? Well, we sort of talked a little bit about this, but arthritis can be post-traumatic after an injury. Infection can cause arthritis. And the reason an infection causes arthritis is that when you have an infection, your body attacks the infection, but those enzymes also eat up your cartilage. There are inflammatory arthritis that are not uncommon, and things like rheumatoid arthritis, psoriatic arthritis, lupus arthritis, and there's a whole slew of autoimmune inflammatory arthritises. And the most common by far arthritis that we see is osteoarthritis, or routine wear and tear arthritis, which is really from aging, and usually there's a genetic component to it as well. So what are the signs and symptoms of arthritis? Well, we've sort of talked about this a little bit, but pain, swelling, warmth, stiffness. Patients get up in the morning, they feel like their hands are stiff, they have to get them moving. Bumps on their finger joints are often indicative of arthritis. Patients will lose motion. So instead of being able to make a complete fist, they may only be able to make a partial fist. Generally, there's pain with activity, and it's better with rest. And finally, arthritis can wax and wane, but it generally will get worse with time. So how do we, as orthopedic surgeons, make the diagnosis? Well, the number one most important thing is a history. Once a patient tells me their story, usually you have a pretty good idea of what's going on. And then we do a physical exam, which involves looking, touching, checking the motion. And with a history and physical exam, probably 90% of the time, we know exactly what's going on. And then we confirm that with an X-ray. Patients will sometimes say, don't you need an MRI? We rarely need an MRI to work up arthritis. It really does not add very much. Now, obviously, there are exceptions. And sometimes somebody with, let's say, rheumatoid arthritis, an MRI might give us a little information. But as a rule, I almost never order an MRI when I see someone with arthritis. And blood tests, again, very, very rarely needed. Again, we get blood tests when we're looking for an inflammatory arthritis. So how do we treat arthritis? And I'm going to go through prevention, different types of treatment, and we'll go through each of these one by one. So how do we prevent arthritis? Well, probably one of the single most important things is to avoid injury to your joints, because when you injure your joint, you can damage the cartilage. I think maintaining a healthy weight will help you prevent arthritis. Healthy diet help prevent arthritis, not a specific anti-inflammatory diet per se, but a healthy diet, exercise regularly, and don't abuse your joints. It doesn't mean don't do things, but when you start to get arthritis, you want to rest your joints more than beat them up. So patients will always ask me, what works better, heat or cold? And generally, patients with arthritis in their hands do better with heat in the morning and then ice after they do something. When you wake up and your hands are stiff and sore, hot packs or heat or a hot shower or a paraffin bath often will help get the joints limber and moving again. And then let's say you have arthritis in your thumb and you go out and do a lot of yard work and it's aching, ice afterwards generally helps. So like anything, everyone's a little different. And I have a few patients who say to me, no, cold always works better. If you're one of those people, do what works for you. But as a rule, heat in the morning, heat to get things going, and then ice to prevent inflammation. Anti-inflammatory medications, Aleve, Motrin, Advil, ibuprofen, and there's a whole slew of them that we prescribe. and they can help with the symptoms of arthritis, but they don't prevent the progression of arthritis. So we don't generally prescribe anti-inflammatories on a regular basis for arthritis of the hand and wrist, but judicious use of anti-inflammatories is a good idea. So if you're going back to that pruning example, you go out and you beat your hands up on Saturday and you come in and they're stiff and sore and achy, maybe a couple of Advil or something like that, assuming you don't have a reason why you can't take it. There are other medications that are used for arthritis, and I'm referring specifically to the medications that are used for the inflammatory arthritis, like rheumatoid arthritis or psoriatic arthritis. Unlike the anti-inflammatories, these medications can actually modify the disease and prevent arthritis and the progression of arthritis if you have an autoimmune disease. They don't work for the wear and tear osteoarthritis, but they do work to help prevent arthritis in people with autoimmune diseases. And those are generally prescribed by a rheumatologist. And then the next thing I want to talk about is splinting. There's a number of splints that you can use if you have arthritis in your wrist or your thumb, and this is just one. And we have a much better splint now we're using for arthritis in the base of the thumb, where you can use it, be active, and do everything. And it allows people to be more active. Injections. So there are a number of things that we can inject into joints. Things like Synvisc or Hyalgan, and there's a whole slew of these viscose supplements that are basically lubricants, and they've been shown to work well in the knee, but there's really no good studies that show they work well in the hand. So we rarely use them in the hand, but every now and then someone will come in and want to try it. And it's not unreasonable. I've had some patients who've had some success. I've also had a lot of patients where it hasn't helped. The downside of this is that these viscose supplements are expensive, and the insurance companies won't pay for them because there's no good studies that show that they really help. So I think it's a couple $100 for the medicine, and if patients want to buy it, we can inject it in there. It is something that people ask me about now and then. Cortisone injections, they work very well at settling down the symptoms. They don't cure arthritis. They don't prevent arthritis. They don't turn the clock back on arthritis. So you want to use cortisone injections judiciously. I don't have numbers, but I don't inject joints 7, 8, 9, 10 times. And I think obviously you've got to take each patient individually, but I try to limit the injections because they sort of trick you into thinking you're fine, and you end up beating up your joints more. So I think if you have a real flare-up, let's say you have some arthritis in your thumb, you go out, you do a lot of yard work, and it's just killing you, and you can't sleep. I think a shot there makes sense, and you got to behave yourself. The next thing I want to talk about is PRP, or platelet-rich plasma. And this is something that's relatively new. Again, there are studies that show that it can help, and other studies show that it doesn't. And there aren't a lot of good studies in the hand. There's some studies in the knee that show that PRP can help with knee arthritis in terms of symptom control. It doesn't put cartilage back on the joints, but it can help with symptom control. Again, this is one of those things that's experimental. It is not covered by insurance. And so for somebody who wants to try it, and we get asked about this a lot, it is something we can try. And it's safer to use in cortisone injections because basically it's taking the platelet-rich part of the plasma and concentrating it and injecting it into the joints, and it seems to turn off the inflammation and settle down the joints without the negative effects of cortisone. These are some treatments that I want to talk about, which again, there's no real good data that show they make a big difference. But some patients find a short course of occupational therapy helpful. It seems to help educate the patients and help them learn how to modify. And it's sometimes helpful. I don't routinely send all my osteoarthritic patients for therapy, but it is something that some patients find helpful. Acupuncture, again, no data, but I've had a few patients tell me that it makes them feel better. I, again, routinely do not use acupuncture, but patients ask me about it. And while I won't recommend it, I certainly don't object to it. And if somebody wants to try it, I don't object to it. And the last thing is vitamins or supplements, things like chondroitin sulfate, turmeric, some of these type of things. Again, there's not a lot of good data. CBD would fall into this category. We don't have data. Some patients find it helpful. Again, I don't have any objection. I don't think it's going to harm you. It's a matter of whether you want to spend the money and give it a try. But there's not a lot of data that show that these make a big difference, and they certainly don't set the clock back or put cartilage back on your joints. So the last thing I want to talk about with regard to arthritis is surgery. When all else fails, there are surgical options for arthritis. Generally, for arthritis in the hands, there's no urgency to rush into surgery. I tell patients you'll know when it's time to have surgery. I will never tell you waited too long. I'll never tell you you should have done this 3 years ago because now I can't fix you. So I try to maximize conservative therapy, and I tell patients when you can't live with it anymore, then it's time to think about surgery. Here's an x-ray on the right, which shows, again, the normal joints. This is a normal x-ray, healthy cartilage. On the left, an arthritic thumb. And the way we treat this, instead of like a knee replacement or a hip replacement where we put in new joints, with the arthritis of the thumb, we take out the arthritic bone and we weave a tendon through there. And you can see here, this is a tendon that we borrow, and we stabilize the thumb and we weave it through here, and it gives us a cushion. It works very well. It doesn't make you perfect like you were when you're 20, but it's good for pain relief. It's good for function. And again, when patients are ready, it's a good option. Here's an x-ray. Again, here's the arthritis over here. And here's after the surgery. You can see the bone is gone, and in here is a cushion of tendon, and it's stabilized. And this is a good operation for the person who has intractable pain or the pain that limits their ability to use their thumbs and is willing to proceed and have surgery. I want to talk a little bit about arthritis of the MP joints. And these are the joints where your fingers meet your hand. Here you can see the bone is rubbing against bone. And here you can see normal cartilage. That's the red arrow is bone against bone. The blue arrow is normal cartilage. And over here, you can see we've replaced the joint and we put in a prosthetic implant. This works pretty well. It doesn't last forever. It doesn't have the same kind of result, let's say, that a knee or hip replacement does, but it's a good option for the person who has very significant pain. And you can see this patient has great motion, and there's really, you can't even barely see, there's a little scar here, but there's no swelling, and this little ring is for a different problem. But this is where the joint was replaced right here, and you can see here the motion is very good. At the PIP joint, which is the next joint out, not the joint closest to your nails, but the joint in the middle of your fingers, there are really two choices if you have surgery. One is a fusion and the other is an arthroplasty. And you can see here, this patient had their knuckles replaced. And we don't do this as often as we do in other areas of the body, because the results of this are good, but they're not as long-standing, let's say, as a knee or hip replacement. But patients who desire, to maintain their motion and who have a lot of pain, this is a reasonable option. And then a fusion is, you can see here, these joints have been fused. They have a screw across them and here, and we can do that same kind of procedure across these joints, but obviously you lose motion, and patients don't do as well losing motion at the PIP joint. Here is someone with arthritis of their thumb at the end joint, right around where their nail is. And you can see there's bone rubbing against bone here. And what we do is we take the joint down, put a screw in, and this works well for the end joints, the joints near your nails. Arthroplasties or putting in prosthetic implants there do not do well. So we generally fuse those joints. So for the DIP joint or the joint nearest to your nail, those joints, if they get bad enough that they need surgery, we generally fuse them. I'm going to talk just a little bit about arthritis of the wrist and surgery for arthritis of the wrist. There's really three main ways to deal with this. One is to remove some of the bones. The other is to fuse part of the wrist, but leave some of the wrist open for motion. And the next one is a complete fusion. Rarely we'll do an arthroplasty or what's called a total wrist replacement, but these are less predictable again than the knees and hips, which do very, very well. So it's much less likely that I would recommend a joint replacement for a wrist like that. So here is someone who has arthritis in their wrist. And again, you can see the red arrow where there's bone rubbing against bone. There's no space like there is here and everywhere else. And in these patients, what we do is we take out the 3 starred bones. And if you look over here, it gives us a new joint where there's now cartilage. And this works very well. It's good to maintain some motion. You lose about half to 2/3 of your motion, but it gives you functional motion. And it's a good option for somebody with pretty significant wrist arthritis who isn't enjoying activities. I've had patients go back to golf and tennis after this procedure, and it's a good operation for the right person. Here's a wrist fusion, and you can see we've taken out the wrist basically, and we've locked it in place with a plate, and this will heal and become one bone. This is really the last ditch effort for somebody who has bad arthritis, because it's a little bit disabling to lose the motion in your wrist. And so I do these very rarely. And the person who gets this is somebody who has, all the joints are shot and they need power and strength. And you can still be very active and functional, but it is a little bit hard when you lose all the motion in your wrists. So this is not one of the first lines of treatment. I briefly want to talk about tendonitis of the hand and wrist because it's frequently confused with arthritis. And I'm going to just talk about deeper veins and trigger fingers. I just saw a patient who said they were going to be on this call, so I wanted to make sure I included deeper veins. But deeper veins is a tendonitis of the wrist. There's pain and swelling along the side of your wrist where the thumb is. You can have limited motion of your thumb. It's generally caused by repetitive use. It's generally caused by your anatomy being a little different. Certainly people are predisposed to it. And many people, it's been called mommy's thumb because a lot of young mothers who have newborns will get this. I've seen it in the grandma who's taking care of their grandchild as well. But it is a very common problem. And it can sometimes people think they're getting arthritis because they'll have a big bump there. It'll be swollen and it can be confused with arthritis, but it's not. It's very easy to treat, very effective treatment. Here's a picture, and you can see over here, this area gets swollen and inflamed. And when you bring your thumb down, it causes a lot of pain. And the way we treat it is rest and ice, immobilization, anti-inflammatories by mouth. And most frequently, a shot of cortisone will often resolve this. And probably 60 to 70% of people are cured forever with this problem, with 1 or 2, possibly a 3rd cortisone injection. And in those people who it just keeps coming back, there's a little minor surgery we do under local anesthesia, which works very well, quick recovery, and it generally resolves the problem. I want to talk a little bit about trigger fingers because, again, many of the symptoms of trigger finger are similar to arthritis. And I have patients come in frequently who have trigger fingers who tell me, I have arthritis, you know, my hands are stiff. I wake up, I feel like I'm 100. I can't move my fingers. It bothers me at night. They get stuck, they catch. And so while it seems to patients like arthritis, it's not arthritis. It's easy to treat. It's a simple problem that has predictable solutions. So this is what a trigger finger is. You can see the tendons swell and they go through this tunnel and they get stuck and they'll catch and pop. So you'll get a nodule on your tendon. So this is a pulley and you have them all the way out to the tip of the finger. And what happens is that tendon is too swollen to get through that tunnel and you'll feel popping, clicking, and catching. And the way we treat this, again, splinting, sometimes observation. If it's very minor, anti-inflammatories by mouth. If it's very minor, almost everyone, by the time they get in my office, it's time to get a cortisone shot. And again, 60 to 70% of people are cured forever with 1, 2, or 3 shots. And the ones that don't, there's a little minor surgery that we do under local. It takes 20 minutes. The recovery is generally fairly quick, although there's a little bit of variability in the recovery of this procedure. But most people do well. Most people, it cures the problem. It doesn't come back. I get often asked, how long is the surgery good for? If it works, it solves your problem. It doesn't come back. So this is a common problem that is often confused with arthritis. And it is very easy to treat, very predictable. So if you have questions about arthritis, you can go to the Johns Hopkins website. And thank you for your time. And we're going to take questions at the end. So I'm going to turn this over now to Dr. Moss.
Great. That was a great talk, Dr. Barth. Thank you.
Okay, let me see. All right, David, I think I'm good. Is David up?
Yep. Can you hear me okay there?
Yes, he's up.
Great.
Okay, perfect.
Great. All right. Hi, my name is Dave Moss, and Dr. Barth and I work together, and we are both orthopedic hand surgeons, as Dr. Barth explained. So we treat disorders of the hand, wrist, and elbow, and the shoulder. Today, I'm going to talk about orthobiologic injections for the hand, wrist, and elbow. This is a little bit different than the title as it was advertised, or as you may have heard, which I think was listed as non-operative treatment for conditions of the hand, wrist, and elbow, but it's a very similar bent. And it actually touches on a few ideas that Dr. Barth brought up in his talk, sort of in the middle region, talking about injections. So we'll talk about orthobiologic injections. What are they? You've probably heard that term, or biologics, or maybe you've heard that term. If not, we're going to talk about it today. You'll learn more about it. So what are orthobiologics or biologics, and do they work? So as physicians, we take the Hippocratic Oath, which can be seen before you there. Basically can be boiled down into the concept of do no harm, but truthfully, as doctors, we really try to relieve pain and suffering and really heal the patient rather than just do no harm. So how do we do that? What is the ideal treatment? How can we get patients better? The ideal treatment would be readily available and easily accessible to everybody. The ideal treatment would be simple to administer, so it'd be very easy to do in a simple setting that's not elaborate and not cumbersome. It would afford a rapid recovery. It'd be low risk and highly efficacious, meaning it would work most of the time or a lot of the time. So high benefit, low risk, we like that, and it would be low cost. So we're looking for that ideal treatment, and that seems to always be an elusive concept. We have some good ways to treat things for sure, but we're always looking for something better. the current ways we have to treat conditions of the hand, wrist, and elbow, or really any other orthopedic condition, consists of many different ways of addressing it or approaching the problem, ranging from activity modification, which basically means if something bothers you, do a little bit less. So Dr. Barr talked about gardening. We see a lot of gardeners in the office. And if you're gardening for 10 hours, 2 or 3 days in a row over the weekend, and your hands come in and they hurt, or your elbows hurt, your doctor might say, why don't you take a little rest? So we call that activity modification, which is sort of a nice way or a euphemism for saying stop doing it if it hurts. Other options we have are splints, which again, Dr. Barth talked about, and you can see a splint there on the right. There's many different types of splints to treat many different types of conditions, ranging from the hand, wrist, or elbow. We have physical therapy, often very helpful for many things, not helpful for everything though. Dr. Barth talked about how it's not always helpful for arthritis. It can have a role, but not always helpful. Oral medications can be helpful, different pills, different types of anti-inflammatories, steroids, all sorts of other different medications. And surgery is another option. Surgery can be helpful as well, and certainly a good option. Not always the first option, but an option depending on your condition, depending what's been done before. All of these treatment methods have benefits or pros, and they have risks or cons, and they all have to be weighed, and that has to be considered with every type of treatment, no matter how you treat a patient. But what about an option like an injection? Injections can seem very promising for any number of reasons. There's a number of injections out there. We talked about cortisone already in this discussion, which I'll talk about briefly. But really, when we're talking about things like biologics, we're considering other types of injections that you may have heard about or you may not have, but things like PRP, APIC, Bmac, whole blood, stem cells, all sorts of different mnemonics and confusing titles and different ways of harvesting these different types of biologics, which can be quite confusing to the consumer or even to the treating physician if you're not boned up on this. So injections are exciting because they're easy to administer. They can often be performed in the office, and they're generally low risk, but not always. But it's good to critique each type of injection one by one, but generally these are low risk. So easy to administer, low risk. The downside is they sometimes can be costly. And then the ultimate question is really, do they work? The risks of administering these, the ease of administration, the cost, it's all sort of worthless if they don't work. So we really have to understand, do these work, and are these the ideal treatment, or can they be the ideal treatment for all of our orthopedic and orthopedic conditions? So just to recap there, we're going to go over what type of injections are available. We're going to talk about what the risks are for certain types of injections. And then we'll discuss, do they work? And are these really the ideal treatment? Because there's a lot of excitement around these for good reason. But let's first start with cortisone. Cortisone is comes in different forms. It can be taken orally. Many of you know about this, or it can be injected as well. And we can inject it directly into joints. We can inject it in or around tendons. We can inject it into muscle or soft tissue to have more of a systemic effect. I'm alluding more towards the type of cortisone injection that is done into a joint or around a tendon. Cortisone for this purpose is readily available. It's inexpensive. It's easy to administer. It's been around for a long time. It has a relatively low side effect profile. It can cause some local problems with the soft tissue, and too much cortisone in the same spot can cause some problems. So you have to be judicious about its use. And it can be used for things like tendinitis or arthritis or generalized inflammation. Does cortisone work? Cortisone has been proven to reduce inflammation. It can improve some types of tendinitis. It typically provides temporary relief from arthritic pain. It does not reverse the arthritic process, but it can relieve pain from arthritis for a period of time ranging 3 to 12 months, 3 to 6 months, something in that range. Cortisone has become somewhat controversial when injecting it in the outside of the elbow. So in the, they call it lateral epicondylitis or tennis elbow. That used to be sort of a go-to for treatment of tennis elbow. It's become a little more controversial with a number of studies over the past few years that have shown that it may not be as effective as it was once billed as, but it's still commonly used for this purpose. I'm sort of bringing this up because a lot of the biologics I'm going to talk to going forward, including stem cells and PRP and other things, are basically utilized in tennis elbow or lateral epicondylitis, and that's the benchmark for testing these different types of injections and comparing them side by side to each other. So this lateral epicondylitis or tennis elbow tendonitis will come up again and again in the course of this talk. And that's, again, sort of the benchmark for discussion of these different biologics, just because it's easy to compare side by side, and that's how the studies have developed. So the takeaway for cortisone is, yes, that it works for proper indications and if you have the proper expectations, but it is effective and it's commonly used. So what about these orthobiologics that I'm talking about? What are orthobiologics? So often we just say biologics. We shorten it up to just saying biologics. And biologics are use of the patient's own cells and their own growth factors to promote tissue healing. So this sounds awesome, right? You can extract something from your own body relatively simply and re-inject it into another part of your body and create a healing process. So this is a phenomenal concept with enormous potential. Let's try to understand it and break it down and sort of unpack it piece by piece and see what we're talking about here. So we're going to start off with talking about PRP. So PRP is platelet-rich plasma. And hopefully you can see the cartoon over here, which shows that platelet-rich plasma, this is the process where platelet-rich plasma we extract this by drawing blood from the patient's arm, and then the blood is spun down in a centrifuge, which separates the cells in the blood based upon the density of the cells. And then a small subset of the cells, the buffy coat, is drawn off and then re-injected into the patient's elbow or wrist or finger or shoulder or whatever the area of pathology is, the area of interest. And this is all done in the office. It takes about a half an hour or so. And it's a commonly used biologic. It's the most commonly used biologic, and it's been around for a while, certainly at least 15 or 20 years, been used commonly, relatively commonly in the orthopedic setting. So in regards to PRP, the benefits are that it's easy to administer. Again, it takes about a half an hour, and it's a blood draw in the office, and then a re-injection at the site of where the pathology or the pain is. It's readily available. It's easy to obtain. And it's overall thought to be very safe with very few side effects. The downsides are that it can be moderately expensive. It does cause local pain at the injection site, sometimes for a few hours, but sometimes even up to a couple of weeks. And then the big question on the table remains, does it work? Is it efficacious? Again, most studies studying PRP are examining its effects in tennis elbow or lateral epicondylitis. And it's been found, even though this has been around for 15 or 20 years, that it's somewhat difficult to standardize the tests and the results with PRP. So there's lots of papers out there discussing PRP and its treatment in the elbow, but the results are very variable for a number of reasons, namely the stage of disease in which the patients present. So if they're mild or moderate or advanced, has not really been standardized among these studies. There's various concentrations. So PRP can be concentrated in certain amounts, 5x of the platelet concentration of the blood, or 8x or 6x. Those numbers are not really standardized in the testing that's been performed and published in the literature. And then additionally, the results are not standardized. So what one study might grade as an excellent result, another study might grade as a moderate or good result. So there's not a lot of standardization in the studies, making a apples to apples, side-by-side comparison of these multiple studies treating lateral epicondylitis with PRP very difficult. However, large samples and studies have been pooled, doing something called a meta-analysis, where they've looked at hundreds or thousands of patients across different studies. And really, the studies do show fairly convincingly that PRP is superior to cortisone in treating lateral epicondylitis. So it is more effective long-term than cortisone. And PRP is generally accepted for use. Over the past 15 or 20 years, it's become a much more common treatment modality. It's simple. The side effect profile is very favorable. It's very low, and it does seem to work. So PRP, we're going to check that off as a biologic that is generally accepted for treatment, and we can recommend that with a fair amount of certainty that this is a favorable treatment that will work or can work. What about APIC? So this is another variation of PRP, or platelet-rich plasma. This is generally used to treat arthritis rather than PRP, which can be used for arthritic conditions or tendinitis or other things as well. Unfortunately, with APIC, it's somewhat of a newer technology, and at this point, there is no definitive evidence for APIC that this is either beneficial or detrimental for the use of treating arthritis at this time. Stem cells are something that I think a lot of us have heard about. It's sort of easier to get your mind around. I'm going to minimize something on my screen here so I can see my whole screen. I'm having a hard time doing that. Stem cells, are mesenchymal stem cells, are basically primitive cells, as you can see in the drawing here on the screen, that have the ability to differentiate into all sorts of different cells. So a stem cell can differentiate into a cartilage cell, or differentiate into a tendon cell, or a muscle cell, or a bone cell. This is extremely exciting. If we could extract cells from the body or from other sources, stem cells come from the patient's own bone marrow, fat, skin. They can be from donor umbilical cord blood, or placenta or amniotic fluid. And there's all sorts of other ethical controversies that would be a whole nother discussion regarding that. But regardless, this is a super exciting concept, where if we could generate cartilage cells, which, with all due respect, we essentially have no way of regenerating cartilage cells in a meaningful way. So if you have arthritis, like Dr. Bart talked about, and your joint is worn out, there's no way we have to restore the surface of that joint and the cartilage to restore normalcy of your joint. If stem cells could do that, this would be an enormous breakthrough and eliminate the need for us to perform joint replacements and do all these other injections. Think about this concept with tendinitis or fractures or all these other conditions that we treat, even beyond orthopedics. So it's extremely exciting. Do stem cells work? We're going to get into that in just a minute, but one of the variations of stem cells, or formulations of stem cells that we use in the orthopedic office from time to time, is called Bmac. As you see, we like to use these different acronyms. Bmac, bone marrow aspirate concentration. And in this scenario, bone marrow cells are aspirated from the hip. This can be performed in the office setting. And the bone marrow cells are concentrated, again, often using a centrifuge, and then re-injected into the site of injury. So as I've alluded to, this is an extremely exciting concept, but do they work? Do stem cells work? And unfortunately, at this time, there's still no definitive evidence for or against the use of stem cells for treatment of upper extremity conditions at this time. And I'm citing a paper here from the Journal of Shoulder and Elbow Surgery, from 2019, which reviewed this critically. So we don't have any clear evidence that this is beneficial. That doesn't mean it doesn't work. It just means we don't have any great evidence at this time, and it's somewhat difficult to collect evidence for the reasons that I alluded to or talked about with the PRP difficulties, where we have difficulty collecting homogeneous evidence in a group of patients that is easy to compare side by side. So there is evidence out there, but the definitive evidence is not there yet. Autologous whole blood, I'm just going to talk about briefly. This just means taking whole blood, so just drawing blood out of your arm, diluting it with a little bit of local anesthetic like lidocaine or bupivacaine, and then re-injecting this into the site of pathology, which again, most studies are using lateral epicondylitis or tennis elbow to compare this. And the gestalt on this, or the overall vibe, is that most studies show that this does have a positive effect. Most patients in this studied group found that it was more beneficial than cortisone, but that it was not quite as good as PRP. So this is used from time to time, and you may see some of these procedures used, I would say, liberally in doctors who are termed regenerative medicine doctors, or non-operative sports doctors, or physiatrists, or other titles might use some of these treatments more often than others. But that's the lay of the land so far on the few biologics that we've discussed in depth today. So in conclusion, the conclusion really is that there is no conclusion at this time, or there's not a overwhelmingly swaying conclusion. Basically, there's inconclusive data on the efficacy of these biologics. Again, that doesn't mean they don't work, but we just don't have great data that shows that they do work. There's a lot of sort of theoretical data or thought concepts, and they seem to make a lot of sense on paper, but in clinical data, researching human subjects, the data is overall inconclusive. Again, to reiterate, this is confounded or confused or made more difficult by the fact that there's enormous variability in the stage of disease in which patients present. No patient's the same. Somebody might have a huge tear of their tendon in their elbow, but they don't present in a way that is dramatic, and they're graded at a lower level. Or somebody might have a small tear and it might be very painful for them. So patients present at different stages with different clinical complaints. The treatment algorithm, so how many shots patients receive, the concentration of PRP, for example, or the volume of stem cells, the stem cells harvested, how things are harvested, has enormous variability, making it, again, difficult to standardize these treatment methods. And then the grading scale is complicated as well. So again, firm scientific evidence is lacking, which doesn't mean there's not value to these, or doesn't mean there's not an indication to perform these, but it just means that the firm level 1 scientific evidence is not there. On the whole, these treatments are extremely benign and are unlikely to cause harm. There's enormous upside potential. So the continued study of these biologics is ongoing and extremely exciting. And as physicians, remain extremely excited about it. But there is need to standardize the administration of these, as we all, underneath the surface, we're all physicians, we're all scientists. We want to do no harm, but we really want to help our patients. And a lot of us would really love more convincing evidence before we formally adopt these biologics into our practice. Again, there is a role for them. We do them. We certainly do them from time to time, or sometimes more frequently than others. But the really convincing data is yet to come, and hopefully that is on the horizon. So if you're a patient thinking about biologics and you're confused by the acronyms alone, let alone the convoluted picture behind it, and this talk, which may not have lent any clarity to you, but basically I think the take home is you have to be judicious and critical when you're considering a biologic, and have an honest discussion with your physician. Try to understand the evidence. We don't expect our patients to read scientific literature and critique it in a scientific manner, but that's really our job to do that with the patient and to help the patient understand what the evidence is. And if you're considering a biologic, that's a discussion you should have with your physician. So thank you very much. That concludes the biologic section of the talk. I see there's lots of questions, and I perused the questions at the beginning of the talk. I'm going to try to stop sharing my screen here. Here we go. So I don't think I did it there. I'll get to try to stop sharing my screen. Here we go. So there's lots of questions, and I looked through the first 30 questions or 20 questions, 22 questions, I think, before I started talking. They were all arthritis. Perhaps the last few questions are on biologics. So maybe what we could do is alternate questions one by one, and maybe Dr. Barth, you want to start at the top of the list and I can start at the bottom or something like that, and we can meet in the middle with going through our questions and trying to answer what the patients have to say.
Okay, so that sounds good. Let's see. Okay, it looks like, and Kathy, you may have to help me if I get a little confused here, but it looks like, can osteoarthritis change into another type of more severe arthritis like psoriatic arthritis? The answer is generally arthritis doesn't change into an inflammatory arthritis. So if you have osteoarthritis, you don't have to worry that you're going to get an inflammatory arthritis. But occasionally someone will present with arthritis that we think is osteoarthritis that turns out to be an inflammatory arthritis like psoriatic arthritis, but that's very, very unusual. And the vast majority of people who have osteoarthritis, you don't have to worry that this is going to become rheumatoid arthritis or psoriatic arthritis. That doesn't happen.
Okay, great. I'm going to answer a question that says, if you use a biologic, will the physician use your results as part of a study group? Maybe, only with your consent. So there are lots of studies going on out there. You'd have to consent to being a part of that study. Dr. Barth and I don't have any ongoing biologic studies, so we're not planning to use you as part of a study, but if you were selected to be part of a study, you'd simply fill out a consent form and they use your results and put that into a larger picture to try to help us understand this picture of what's going on with biologics. So only with your consent, and Dr. Barth and I don't have any of that going on.
Okay. Do topical gels have any efficacy versus the pills such as diclofenac? That's a very, very good question. The data on the topical gels is frankly very, very mixed, kind of like some of the things that Dr. Moss talked about. So there are some studies that seem to show there is efficacy, and then there are studies that show there isn't. My feeling on topical gels are they are unlikely to cause any harm, and as long as you use them as they're prescribed and don't overdo it. And I think it is a very reasonable thing to do. They're over the counter now. You can get them without a prescription. I don't know how expensive they are in the pharmacy, but I think if you're willing to give it a try, I think it's a reasonable thing to do. I think the data, though, is mixed and limited.
Okay, a couple of questions. One asked about our transcripts. I'd say if you're interested in our transcripts, go to WOSM.com and they're available there. Kathy may have a way of sending it out to the group, but I would just go to our website at WOSM.com. The second thing I'd like to say is we're checking the Q&A file. We're trying to check the Q&A file over the chat file. So if you do have a question, please try to put it in the Q&A rather than the chat. We'll try to get to both. And then lastly, answering an orthopedic question, Linda asks, is the tissue damage in the hand from a cortisone injection permanent, or can the tissue regenerate? Can a cortisone injection be used in the upper palm to minimize pain in that area? So yes and no. So, tissue damage, if you've had too much cortisone, can be permanent. It can cause things like fat wasting or degeneration of the underlying tissue. So that's why we don't do it. It can destabilize joints. It can actually cause arthritis or other conditions to actually worsen over time. So if you destabilize a joint and you're trying to treat the arthritic pain underneath, but you've gotten 10 shots and a soft tissue shot, then the joint's going to become unstable and cause a more serious problem. So that tissue cannot always regenerate if you've abused the cortisone. And then can it be used in the upper palm? It completely depends on what the problem is. So I can't really answer that authoritatively. It depends what the specific diagnosis is.
I'm going to there was one question that I skipped, but the question was, will we get written replies to all these questions? The answer is no. We'll go through all these questions. We're not going to respond in written form. These questions are for discussion for everyone. So the next question is, what helps nodules and malformation of the digits with arthritis? Are acetaminophen or glucosamine helpful? Other possible non-surgical help? Unfortunately, when you get the nodules and the deformity, there's really no non-surgical solution in terms of getting rid of the bumps or the deformity. What can help is acetaminophen, Advil, Aleve. In terms of the symptoms, glucosamine may help with the symptoms, but it does not reverse the arthritis. It doesn't get rid of the bumps. It doesn't get rid of the deformity.
Okay, I've seen a couple questions about this. This is sort of an arthritic question, but I'll field it where they talk about putty and other things that are often used for hand therapy, and those can be very helpful. Putty or squeezing a ball in certain situations, those can be very helpful. They can also cause irritation. So if you do too much putty or too much squeezing of a tennis ball or a stress ball or things like that, that can cause irritation or inflammation. So I'd say everything in moderation, and like squeezing a tennis ball doesn't cure all hand conditions. And a lot of times people have a certain condition, they say, I'm going to squeeze a stress ball, but that can make it worse. So it really depends on what you have. And again, it's that's something that might be better to talk to Dr. Barth and I specifically about. So in the office where we can formulate a diagnosis and then figure out the best way to treat it. Putty doesn't cure everything. Squeezing a tennis ball doesn't cure everything, but it is good for some things.
The next question is, I read recently in the popular press that Paxil type drugs may be the first drug to treat osteoarthritis. Comments. I have not seen that in our literature. There are some drugs like Paxil, for example, Cymbalta, which has been found to be effective in patients with pain. So that may be what this is referring to, but we generally don't use Paxil type drugs to treat arthritis. That would maybe be a question that you'd ask your internist or rheumatologist, but that isn't something that we do, and we don't have literature in our literature that says that that is a first line treatment for arthritis.
This is a good question. Are there biologics that are contraindicated for cancer survivors? That's a great question. So biologics depend on your own cells, your own healthy cells. If you have cancer, those cells might be altered or might be different. And if you've had treatment for cancer, like chemo or radiation, that can diminish your blood counts, platelets, red cells, various other cell counts in your blood. So I think it's probably reasonable to assume that biologics may be less effective if you've had treatment for cancer or if you've had certain types of cancer. The second part of this question, have you injected biologics in the hands of patients who've had lymph nodes removed from that arm? I have not specifically done that. I don't see a contraindication. This might be a breast cancer survivor who had lymph node dissection in the axillary nodes. That is commonly a source of angst for breast cancer survivors who have had axillary lymph node dissections, where they're often told that nobody should ever touch that arm again. That's a whole nother discussion, but often we can do treatment safely in those arms that have had axillary node dissections for those breast cancer survivors. So that's another topic, but we'd be happy to talk more about that in the office.
I'm going to answer, there's a couple that are similar right here that I'm going to go through. Dr. Moss already answered, will therapy every day help, or is this too much exercise? Do you always see swelling in arthritis of the wrist? And the answer is you don't always see swelling, but as it advances, you will start to see swelling. And another question was, can the cartilage grow back with rest, etc.? And cartilage does not grow back. And then the next question that's sort of related is, how does rest help arthritis? And the answer is, arthritis involves inflammation. So one of the ways we treat inflammation, I'm sure you've seen the acronym RICE. So rest, ice, compression, and anti-inflammatories or whatever is how we treat inflammation. So that's how rest helps arthritis. So go ahead, Dr. Moss.
Okay, Richard, you went dark on us there, so you're like a
I know, I have to fix my light here.
Okay. So I got a good question here. Where'd it go? There's a few good questions, lots of good questions actually, but one here is, I've had successful biologic treatment, but it was very expensive. Why are biologic treatments not covered by insurance? Great question. So biologic treatments can be very expensive. They can be several $1,000s per shot. Some doctors recommend a few shots to treat something, a shot every week for a few weeks or things like that. Insurance tends to cover things that have good literature that supports the use of it. Not always. I mean, insurance is not the benchmark for what works and what doesn't work in medicine, but it's a pretty good bellwether for what works and what doesn't. And if insurance doesn't cover it, it's because they think that it may not work. So that's probably why, and I'm not an insurance agent, so I can't speak definitively, but that's probably why insurance doesn't cover these treatments. So that just speaks to my point that I think you have to be really critical, very judicious, have a really honest conversation with your treating physician about whether this is right for you, does it work, and is it the right treatment for your condition. So just be really thoughtful about it. Just because insurance doesn't cover it doesn't mean it doesn't work, but it is something to think about. It certainly makes you gives you more pause before you reach into your wallet and pay for something out of your own pocket. Richard?
The next question is, what about Voltaren for pain control? Again, Voltaren is an anti-inflammatory like Aleve, Motrin, Advil, Mobic. It's one of the many anti-inflammatories we prescribe for pain control. And the next question was, what exactly is that new splint and where can it be purchased? The splint that I was talking about for arthritis of the thumb is called an Actimove, A-C-T-I-M-O-V-E, Actimove splint, which my patients find is very helpful. And it allows you to be active and it protects your thumb.
Okay, great. I got a question here. What is the non-surgical treatment for Dupatrin's contracture? Great question. Dupatrin's contracture is when your hand sort of starts to curl in. It happens in Northern Europeans typically, or people of Northern European ancestry. The hand can curl in and get sort of stuck like that, and you can't open it all the way. It can sometimes be rather severe. That was actually the initial thought that I was going to do my talk on that when I was thinking non-operative treatment of orthopedic or hand conditions. I sort of transitioned into the biologics, but Dupatrin is another very interesting topic, and there are lots of interesting treatments for it beyond surgery. Surgery works very well for it, but there are other treatments that are not exactly, well, one is a needle procedure where you can break it up, and one is a different type of biologic where you can inject an enzyme into the cord that's into the hand, and that dissolves the contraction, helps the hand open up. So that I guess that does pertain directly to this talk, but we didn't cover it tonight. So that's another thing that might be better to talk just in the office about Dupatrin's contracture, but another interesting topic for discussion.
Okay, the next question I think Dr. Moss already addressed. Does working with a soft, small ball help to keep the fingers more limber? Again, I think it's been addressed. It's probably patient to patient, and it's probably judicious. You don't want to overdo it. Does arthritis in the hand usually begin in the thumb? The answer is no, not necessarily, but arthritis in the thumb is extremely common. So we see that all the time. And the next question as part of this is CBD lotion or freeze? Is freeze helping provide relief, even if temporary? There are patients who tell me that CBD or some type of freeze spray helps them. Again, the data isn't really there, but if it works for you, then I think it's a reasonable, low risk thing to do. And I think I wouldn't certainly recommend it because there's no data, but I think trying these type of things, if you're so inclined and they work for you, I think that's great. There are things that don't work for everybody, but seem to work for some people. Go ahead, David.
Okay, great. I'm seeing a couple questions on paraffin. It looks like it might be the same attendee asking the same question in a few different posts here, but paraffin can be helpful. Paraffin's just like a waxy dip that's warm, feels great. Certainly great for arthritis. It provides a deep warmth into the joints, makes things feel better. It can be used all the time, very frequently. They have home kits that you can purchase on your own and use them, or you can go to a therapist to get it. So that's great. Another post from Toby about trigger finger in my thumb. They told him I can only have 2 shots. Yeah, we can do a few shots for trigger finger. Generally, the literature does sort of support the use of 2 shots. And after that, the likelihood of a 3rd shot working is fairly small. It's not 0. So if you wanted to do a 3rd shot and give it a go, Dr. Barth and I would be happy to do it. But if you're being very critical, most studies do show that if 2 shots don't work, 3, 4, 5, 6 are not going to work. And going to the surgical procedure, which is very small and takes 15, 20 minutes, is certainly a reasonable course of action. Dr. Barth?
The next question is, how does obesity attribute to arthritis? Well, certainly in the lower extremities, you can understand how the more load you're putting on your joints, the more likely they're going to wear out. I don't know that I can answer it in the hand and upper extremity, except to tell you that it is clearly associated. So it's one of those things that there's probably a lot of theories about why it is. I'm not sure that I can answer for you why it is, but it has been shown to be related to arthritis in the hands and wrist. Okay,
good answer. So let's see, question here. Are biologics available for carpal tunnel syndrome? They are certainly available, and I'm sure there are people administering biologics for all sorts of ailments. I'm not aware of any literature that supports the use of them in carpal tunnel syndrome, but we often give cortisone for carpal tunnel syndrome, for mild carpal tunnel syndrome, and that helps diminish inflammation. Carpal tunnel is numbness in these 3 fingers, often occurs at night, drop things, the nerve is compressed here in the wrist. So if you can administer cortisone and diminish the inflammation around the nerve, that can be very helpful. If a biologic works in the same way and can diminish inflammation, that sounds very reasonable. Again, I'm not aware of any good level 1 studies that support the use of biologics for carpal tunnel syndrome, but I'd be very willing to review one if it came across my desk, or I saw one in a journal, or somebody emailed them to me. I'm very open to the use of this, but again, we want to be judicious and use it for proper indications. And as one reader or one attendee noted, these can be very expensive. So it may not be something you want to experiment with willy-nilly unless the data is there. That sort of, it depends on your inclination to incur risk or financial loss. Richard?
The next question is, what was the second treatment after cortisone and before OT? I'm not quite sure I know what this is in reference to, but if you're talking about arthritis of the thumb, the options are anti-inflammatories by mouth, cortisone injection, splinting, occupational therapy, and surgery. Some of the things I discussed as well include, I talked a little bit about acupuncture, that there's no data that shows that it helps with arthritis, but I have a few patients ask about it, and a few patients have told me it helps them. I have no objection. And then I talked a little bit about vitamins and supplements, things like turmeric or glucosamine. Again, no real data, but a few patients have told me that it helps them, and it doesn't hurt you. And so if you're so inclined, I would not object to trying that.
Okay, I think I'm working my way back up towards Dr. Barth in the back. I think we're starting to get some repeats here. We've covered a lot of these. I think I've covered most things. There's a question here about chemo hand. I'm not familiar with that term. It says my fingers and thumb are numb. Our thumb on the hand were injected with chemo in 1990, became inflamed, deformed after a year of chemo. Chemo can affect nerves and can affect other things. Chemotherapy, soft tissue, can cause skin stiffness and other problems like that. So chemotherapy can have the effect on hands. I think that's a question that may need to be examined individually by myself or Dr. Barth in the office would probably be a better setting for that. I'm seeing a lot of repeats here and a lot of very specific questions that I think would be better treated in the office. Dr. Barth, do you want to wrap it up with one more? And then,
I have. Okay. So there's a couple questions here about cortisone injections. What are the negative effects of cortisone injections? Cortisone is safe used judiciously. Over time, if you, let's say a trigger finger, you injected it 5, 6, 7, 8 times, there's been reports of tendon rupture, pulley ruptures. So they can do damage to the soft tissues. In the joints, they cause damage to the joints. So I don't know if Dr. Moss has numbers. I don't have hard and fast numbers, but I tend not to want to inject joints more than a few times. And I tend not to do trigger finger injections. I try not to do it more than 3 times. Obviously, there are exceptions. I took care of somebody who had arthritis in their thumb, who'd had 8 injections. And when I did the surgery, I had not done the injections. I would never do 8. When I did the surgery, the soft tissues were like tissue paper. We put a retractor in and the tissue just tore. And so I think, the cortisone causes damage to the soft tissue in the joint if done excessively. And then along the same lines, someone asked, what are the negative effects of cortisone injections, especially vis-a-vis Hashimoto's thyroiditis autoimmune patients? I know of no issue regarding cortisone injections and Hashimoto's thyroiditis. Let me just look from my end, David, and see if there's anything. So there's a couple of questions about arthritis of the thumb. Can it be the result of repetitive movement? Generally not. It wears out with time, and it's just a part of growing up, and it doesn't have to be caused by anything in particular. But no, I don't think computer use has anything to do with arthritis in the thumb. Where does cartilage come from? When you perform surgery, we cannot replace cartilage. So we are never going to put new cartilage on a joint at this time. I think at some point in the future, there's research in regenerating cartilage, but we're a ways away from that. And then one more for thumb surgery. When you use a tendon, where does the tendon come from? There's a number of tendons that are redundant, where you can take them and use them, and you have redundancy. So what we usually use for the thumb, or what I use, is the flexor carpi radialis tendon. And there is really there's no real loss for 99.9% of the population when you use the FCR tendon. It's redundant. You have other things that do the same thing. And let me just go. There's a lot of thumb arthritis questions in a row here. What is the downside? Let me just, with thumb arthritis, how long does the surgery work for? The beauty of thumb arthritis is if the surgery works, it lasts for your lifetime because we don't put in foreign material like an implant that wears out. So generally, if it works, and it doesn't get worse with time. Gosh. David, why don't you work up a little more, because there's a few more, and then maybe we'll get why don't you do a couple more, and then we'll call it a night, because there's towards my end, there's a few more.
Okay, so I see one here about trigger finger. Can it be cured with a splint over time? Trigger finger is an inflammatory process, so perhaps shutting the finger down could limit the inflammation, which is a common principle of orthopedics. REST, it's the RICE acronym that Dr. Barth discussed earlier. REST helps almost everything. However, the hand tends to get stiff really quickly, so everything has a, every action has a reaction, and if you put a splint on a finger, you may limit the inflammation of the tendon a little bit by limiting the motion, but then you might create stiffness or have other adverse effects that can result. So the answer is probably a splint would help, but that's not our go-to. Usually I prefer a cortisone injection, which tends to, it is a shot, but it provides quick relief and it doesn't limit motion, and you don't have to wear a splint for weeks and on end or months on end and end up with a result in stiffness. So that's the answer, my answer to that one. Okay,
I think we've met now. I'm going to answer a couple more and we'll call it a night. The one question is the surgery under general or local? I don't know which surgery you're referring to, but 99% of the surgery that Dr. Moss and I do is either under local or what we call regional. We almost never use general anesthesia. So I would say trigger fingers, carpal tunnel, decurvains, a number of other surgeries we do under local. And if you're talking about a thumb arthritis surgery, we do that under regional, where we numb your arm up and you get a little sedation, kind of like a colonoscopy. What procedure is better for carpal tunnel, endoscopic or open? Both work equally well. The endoscopic procedure, patients may get a little bit, may get better a little bit quicker. So for somebody who's very active, an endoscopic procedure may be a better option. And does trigger finger occur in the thumbs? Yes, it does. So I think I guess there's one more here. With thumb arthritis, can you wear your splints too much? I mean, I guess you probably could, but generally my recommendation is you wear them when you're doing things and you're active, and you take them off, when you're more sedentary. I think the risk of wearing splints all the time is that you get a little more atrophy or a little more disuse atrophy. So I generally wouldn't have you wear them all the time, but I never like to say never. I think, we individualize treatment, and there are cases where somebody would wear them all the time. And I think we've met here, Dave. And so I think we've covered everything.
There are a few specific questions that I just recommend that, they're too focused for this conversation. Please call Dr. Barth or myself, or you can go to WOSM.com and make an appointment with us to discuss the more specific questions. But yeah, thank you everybody for coming. This was nice. Thanks, Dr. Barth. Thank you to our sign language interpreters.
And thanks, Kathy, for putting it together. We both appreciate it. And thanks again, and have a good night.
Good night, everybody.